be okay with what you're able and capable of doing. It's a journey just like everything, just like the lifelong learning of being a physician, right? It's true. Every 5 years, what you learned is wrong. We
all know that.
Yeah.
Well, hello and welcome to the Hat Rack again. I'm Dr. Bill McCauley, the Associate Dean of Continuing Professional Development and Faculty Development at the Schulich School of Medicine and Dentistry. And we're celebrating fall here in London. We're recording this in fall. And one of the things that we're noticing is we've got a brand new medical class here. And I'd say that one of the things that we're celebrating about our medical class is that we have noticed an increase in the diversity of students that we're seeing. So we've had some presentations recently where we've seen the data over the years, and we're really making great progress towards diversifying the student class, both in terms of gender and ethnicity and culture and color. And so we thought that in recognition of that, we thought we should talk about that in the context of CPD and continuing professional development. So to that end, I am really happy to have two guests with me here today. First is Dr. Sukhi Bains, who is the acting, I think still. Are they still calling it acting? Yeah. Acting Associate Dean, although she's a phenomenal actor. She's the Acting Associate Dean of Equity, Diversity, and Inclusion here at the Schulich School of Medicine and Dentistry. Welcome, Sukhi.
Thank you for having me.
Oh, it's great. So great to have you. And Dr. Justin Lamb. And Justin is a relatively new faculty member here at Schulich, comes to us from a large school to the east of us in Toronto. Justin is a pediatrician and is an assistant dean, assistant professor. Sorry, I'm getting ahead of myself for you, Justin. Someday you'll be more than an assistant dean. You are an assistant professor in the Faculty of Medicine and Dentistry in the Department of Pediatrics. Welcome.
Thanks for having me. Excited to be here.
Yeah, I should say, I have to say that Justin is here because of his interest in EDI, but I became introduced to Justin when I was at a research symposium, and he got up to present a paper, and I heard his voice, and I turned around and said, that voice has to be on the Hat Rack. So we're pleased to have you. So before we get into this, maybe I'd just like to ask each of you to introduce yourselves a little bit and tell us maybe how you got involved or interested in working in the area of EDID. Sukhi, we'll start with you.
Sure. So I took a bit of a circuitous path, I think, into medicine, which is where my interest in equity, diversity, inclusion, and decolonization sort of came through. I have a background in sociology, and I did all of my medical training in the United States, and so the conversations regarding what is referred to as DEI in that space, but same words, different order, is one rooted in and probably has been more vocalized for much longer than the conversations being had here. And where my interest really came was I've always wanted to bring a sociological lens. I was either going to do a PhD in sociology or do an MD. And now in my current role, it feels like that has been able to be achieved in bringing really a structural lens to the conversation around health inequities and how we're training future providers to be able to effectively care for an increasingly diverse population, which is the mechanism of how our population in Canada is really going to grow over the next, the foreseeable future in terms of the demographic changes. And how we as providers, as our responsibility to the public is central to be able to adapt and also include those experiences and voices in the ways in which we provide healthcare and effectively allow populations to achieve the level of health that they would like to in the ways in which they live their lives. And so having the diversity of experience of only working in safety net hospitals in the United States, where healthcare is very different, but the challenges are actually very similar, is sort of the lens that I bring here back to Western, where I did my undergrad and graduate studies, to try and support, empower, and engage the faculty to feel as though this is something that they're capable of doing, and that it's also going to make it so much more richer of an experience to be an educator in the medical school environment.
Great. A couple of things there we'll come back to. I like the concept of teaching to the future generation of healthcare providers, but also a focus on faculty, because those two things are going to clash with CPD, I think. Justin, how did you come to get involved in this area?
Yeah. I just wanted to add, before I talk about myself, Sukhi, it's not too late to do that PhD in sociology.
It's never too late.
I'm going to wait for you to graduate so you can supervise me.
Speaking of CPD, but no, that's it's so great to hear, Sukhi, about your path and kind of your story, and it has me reflecting on my path as well. I have a background in art history, actually, and through that, I also fostered an interest in sociology and an interest in education. And I'm actually in the middle of a PhD right now in health professions education research. And throughout my medical training, I had been involved in research looking into and exploring and understanding really the experiences that trainees from racialized and marginalized backgrounds have throughout the course of their training. And a lot of my interest stemmed from the realization that, we're inviting folks from, for underrepresented backgrounds, marginalized backgrounds into the medical profession, into medical training. But what we're also seeing in the literature, and what I was also hearing from my friends, is they're having very different experiences, and some very challenging experiences throughout their training that not everyone actually has in training. And so it really came out of that, came out of noticing that, hey, we're not all having the same or similar experiences, and some of us are experiencing more barriers and experiencing more challenges when it comes to their training. And let's understand why that's happening. I don't think anyone within our profession, whether it's a trainee or it's someone who's supervising or any of the faculty, no one goes into their workday or goes into a clinical environment and says, "Hey, I want to make life hard for someone," or I want to, um, I, yeah, I think not. No one goes to work that way. So I really wanted to understand, what is it that's causing this? What are people experiencing, and how can we make things better? And I think, there's such an important lens here to look at this through CPD and faculty development. So thanks for having me here.
That's great. We all have an academic lens, because we all are physicians that work in an academic capacity. And some of our audience are non-academics, they're physicians in practice. So one of the questions I might have is, why is this important? Why is it important that someone intentionally learn about concepts of ED-ID, a physician in practice, whether they be a rural-based physician or an urban-based physician? Sukhi, why would you say that it's important for someone to be knowledgeable about concepts and the importance of ED-ID?
Yeah, I think, especially, I'll speak specifically. I think if you aren't even in an academic environment, just in the community, and perhaps even sort of formal education provision isn't a part of even your practice. I think healthcare is a challenging landscape now. I think there's a lot of stressors. Actually, not even now. It's been challenging. But sometimes it can feel paralyzing if you don't feel comfortable, especially in having to meet the needs and requirements and challenges that come with populations that are either new to the region that you're in, or are also struggling with navigating a system that you grew up in or are very familiar with. And that translates to things like being able to adhere to a treatment plan, whether it was created through a shared decision-making method, hopefully, or not, and trying to achieve health outcomes without understanding the context of lived experiences of those that you're caring for, can make it feel like you're missing parts of what you sort of need to know, but don't necessarily have the time to be able to learn or balance with all the other responsibilities you have. So I think that conceptualizing the application of concepts of ED-ID into the clinical environment really come to the pieces of communication and knowledge translation and impact. Our responsibility is very much so to provide the best healthcare and medical care and application of medical knowledge to every clinical encounter that we have. However, the ways in which that plays out is very different for everyone, because not everyone has the same choices to make. And I think it could be really enriching and helpful for what I think often contributes to the high levels of burnout that we're seeing, of not being able to feel like you're being effective, and not feeling like that's something that is allowed, and not being seen and seeing the level of challenges that are being experienced in the community by providers.
Right. So there's also a physician well-being component to this, you think?
Oh, yeah.
Yeah. Justin, do you have anything to add to that?
Oh, totally. Just I totally agree with everything that Sukhi said, and to build on that, right? I think I absolutely agree that it relates to the care we provide for our patients, and I think one of the fundamental pieces of the concept of equity is recognizing that different folks, for reasons out of their control, for the socioeconomic bracket they were born into, their immigration status, their citizenship, all these other things. Different patients are going to need different levels of support to achieve equal outcomes or similar, as similar as possible, health outcomes as possible. And I think that's really one of the fundamental concepts of equity, right? It's the idea that different folks are going to need different kinds of supports to navigate a system that we all know is complex, and challenging to find your way through. And really, I think our goal is always to provide the absolute best care possible. And by understanding some of these concepts of equity, I think it allows us to be more precise with the care we deliver, so that, every single patient we see, we're able to support to, achieve hopefully optimal health outcomes.
Great. So I think we all know that the term EDID stands for equity, diversity, inclusion, decolonization, and those are all quite distinct things, but obviously interconnected. And one of the things that connects them is that concept of discrimination. And any discrimination is rooted in a bias, in an inherent bias. And I think that in this area, one of the things that people could benefit from was helping to understand what their own inherent biases are. Are there ways that physicians in practice, or that anyone in general can, or resources that people can go to help to understand what their biases might be?
There are many. I will shamelessly plug the website of the Schulich Office of EDID here. We have an entire page dedicated to bias and also microaggressions. And I think, so Bill and I are both Emerge docs. And what I often say is, if you don't think of it, you miss it. And oftentimes it's just awareness, right? Like, one piece, even whoever's listening to this, you're curious, right? There is at least an opportunity to want to think about something in a different way, or maybe looking for either an opportunity to see a way into wading into the space, or whatever it is that brings you here. And so there are a giant gamut of ways in which you can sort of explore different biases. The most, I think, famous one is probably Project Implicit through Harvard, which is just a massive continuous study of big data that's international, that sort of looks at, it's not a bias test and it's not deterministic. But what it is basically a test that looks at your reaction and sort of what I work in any sort of heuristics-based practice like emergency medicine works in, is like, what are your automatic responses to something? And using reaction times and using prompts, they sort of determine where you may have a bias towards. And it's reflective of how we're all socialized, right? So having a bias towards thinking that males are in leadership is not something that happened in a vacuum. It's something that either, if you're completely you grow up in a culture where that was the norm, then that may be where your biases lie. It's something that you have to actively work against. And someone taking that Project Implicit sort of type of test It would be different for someone who, like, I'm 42 or I'm 41, almost 42, I guess, but than someone who is, 15, or because they have been exposed to things that are very, very different. So there's bias trainings and trainings around microaggressions that happen at Western University, and also the opportunities to explore those topics in CPD also that we're working with CPD on. So I think the opportunities are endless and the applications are as well. There's no prescriptive way to do it. It's just wanting to engage and sort of find your way. And if you're looking again for an area to start looking at resources that may be especially applicable to medicine, check out the Schulich EDID website.
There you go. Yeah, I think the concept of it, at the very least, trying to bring into your own consciousness what your biases may be, can be an enlightening exercise for people to at least, anytime you're bringing these sorts of things into the front of your head, I think is important. Justin, one of the things that Sukhi brought up a little bit earlier on was the concept of equity as it relates to socioeconomic status, and I think that my sense, and I might be wrong, but my sense is that's not one of the things that people inherently think about when they think about these concepts of EDID. I think they think about culture, and they think about race, and they think about gender, but socioeconomic equity and discrimination, particularly as it applies to healthcare, is not an area that I think naturally comes to people's minds. So, what do you think about that? And do you agree with that?
Yeah, for sure. Thanks so much for bringing that up. I think um, socioeconomic status and kind of its impact on, whether someone's able to access care, whether it's, how much parking costs, how much it plays out in so much of the patient experience, right? Whether it's, can I afford to buy food at the hospital? Can I afford to pay for parking every night? Can I afford to be off time in my job? Do I have the job security? And do I have benefits to protect? Will I lose my job through the fact that, I'm either taking care of a loved one in the hospital, or I'm in the hospital or having to seek healthcare myself, right? Either whether that's, as an inpatient or outpatient basis. Um, and I think what Suki mentioned, right? And what you mentioned as well, just bringing that to the front of our minds. And if you're not thinking about it, then, that's the first step, right? And taking a growth mindset approach to it, I think is so, so, so important. So I think at the crux of it, it's knowing your community, right? And knowing the community that you serve, and knowing kind of which demographic factors are the ones that might impact the care that the ways that people access care, the ways that people are able to follow through on care and seeking care. I think that it all comes back to how can we provide the best possible patient care for the patients that we see. And I think knowing your community, knowing your coworkers, I think those are all aspects where equity, diversity, inclusion, and decolonization all fit in.
I think we do know that there are often connections between socioeconomic status and some of the other aspects of EDI, such as race and culture. And it's my sense, anyway, that I think that people from a lower socioeconomic status, irrespective of their culture, are often discriminated against in terms of the way that care is provided to them, in terms of the advocacy that goes on for people from a lower socioeconomic status. So I think it's something important for us to consider. Suki, and you look like you're ready to jump.
So here's my well, obviously the concept that we're talking about is right intersectionality, and the ways in which many levels of potential structural violence that people experience systemically is going to potentiate their inability or ability to achieve health equity. I think the part around just one's ability to be a productive economic entity in society is so deterministic, unfortunately, but I don't think something that we should shy away from, and also see also as an opportunity. I think that no one is one thing, and the amount of the ways in which people with what resources they have navigate their lives, and the skills they have to do so, are also something that I think is a a potential to change the narrative for people who have been marginalized to take a strengths-based approach as well. Of like I often say, I've practiced what is quote unquote called street medicine around people speaking or experiencing homelessness when I worked in Chicago. And one thing I often said, especially to learners, was just like, imagine if, first of all, like we know things like housing insecurity and chronic housing insecurity can take over 20 years off your life. It is a health condition. And imagine if people who have survived in the most dire of circumstances, the skills they have for that, if that could be channeled towards, curing cancer. Like there's an incredible amount of skill and depth of experience which no one asked for, and everyone I hope hopes that they never had to develop. But there is incredible strength in communities that have experienced structural marginalization and oppression and discrimination. And so I think that it's also an opportunity to engage in all of our allied health disciplines, right? Like this is the hope for team-based care. This is also, again, in thinking about the enormity of the challenges faced by community docs.
Justin, one of the other areas, the second D in EDID is decolonization, and we've just not too long ago celebrated our National Day for Truth and Reconciliation, and we know that our Indigenous patients have different needs with respect to their health care in terms of how that health care is provided to them. How do we, as healthcare providers, learn a little bit more about concepts related to decolonization and the importance of providing care to the Indigenous population that is going to suit their needs?
Yeah, I think that's a really important question, Bill, and I think it comes down to the principles that we've talked about already, right? Looking for different opportunities to learn. Looking for the way I think about it is what would I do if a patient came in with a condition that I knew that I hadn't seen before, or that's new to me, or it's presenting in a slightly different way than it has before. Maybe it's just slightly different. I would look it up. I would ask my friends. I would look for resources. And I think in that's a similar vein. It's about finding resources, things like the Truth and Reconciliation report. There's a fantastic report that came out of BC, and where there are learning opportunities, looking for opportunities to join workshops. If you're going to a conference and there's a workshop on how to care for patients from Indigenous backgrounds, jumping into that, right? And really taking a growth mindset to it. I think one of the important things to recognize, right, is that we're not going to become experts in equity. We're not going to be experts in anti-racism and anti-oppression. We're not going to become experts in decolonization overnight, right? It's an ongoing process of learning and unlearning some of the things that colonialism and the colonial structures that we live in have taught us, right? I think it's such an important first step to working well with patients from Indigenous backgrounds.
Okay. So,
May I?
Here we go. Yes, I forgot. Sorry.
I see this as an opportunity to also sort of encompass the difference of what decolonization is, right? We add it on, so equity, diversity, inclusion, they're like parallel paths, but not the same. And I think that, as Justin mentioned, the importance of one, how do we know things? So epistemology, but like the different ways of knowing, and decolonization specifically is something for everyone. It isn't it is led by Indigenous voices. However, the stark difference for me, and I speak for myself in this, but also based on literature, is sovereignty, right? Is self-determination. That is something that is a responsibility, and something that is a part of the history of what we now, the country that we call Canada, and we live in and play and work. The specificity around working alongside and with Indigenous communities, and especially in healthcare, is the recognition that there is specificity there. There is responsibility constitutionally, and the right to self-determination and sovereignty, and the respect for that, and the different ways of knowing, and the right to live in ways in which that are in line and congruent with the different nations that are on this land, that have been since time immemorial, is really important to differentiate between sort of basic conversations around EDI.
So first, I have to say I have to agree with Justin, because you're already talking like someone with a PhD in sociology. So you might as well just close that circle. Yeah, I wanted to something, Sukhi, you brought up earlier was the concept of faculty and learners, and I think this is a space, one of those areas in which the younger generation is really leading the more experienced generation, such as myself, right? And so that's kind of turns the tables a little bit on how CPD often what it looks like. So, how, as physicians in practice, can we utilize the younger generation's perspective, which is often much more diverse and open than that of an older generation? How can we utilize that in our learning?
I'm going to bring something that Jess and I have also spoken about. I'm so glad you're here. Concurrently, is really like flipping the narrative, right, around like co-curricular, like co-design around faculty development, right, and that's what we're hoping to work on. Is the knowledge and experiences and the socialization of the current classes and those that are going to come like subsequently is very different, because again, nothing happens in a vacuum. The process of even TRC happened while they were in school. The ways in which the responsibilities are now coming, in an about time sort of way, as a nation, is something that they have acutely been a part of, and is a part of their collective memory. And that is not the same for those who are currently teaching them. And so I think that the opportunity again provides space to rethink what expertise even means. Like, I never say I'm not an expert in EDID. I'm an expert in my own lived experience, and I am a learner always first. I seek to know. I don't assume to know anything. I seek to learn. And that doesn't mean I'm not confident or capable in the responsibilities that I have as an emergency medicine physician or in any other aspect of my life. It just means that I recognize fallibility. And I think that in that space allows some great opportunity to say, hey, we should have a diverse understanding of even expertise and excellence. And in recognizing the immense attributes and assets that we have among learners now, to teach us and to use the experiences that we have in knowledge translation to our colleagues, and the knowledge base that we have the opportunity to engage with learners, is just potentially immensely powerful in creating opportunities for continuing professional development and faculty development, because again, that knowledge translation piece does require knowing your audience. And that is something that I think faculty would probably have a better understanding in terms of their colleagues of like what will work and what will not.
Oh, totally. Yeah. No, I think those are such important things. And I've been also involved and seen other examples where curricula is co-designed with learner input, and the ideas that come out, the ways of doing, the different types of expertise, and the expertise of, say, of lived experiences that come out, right, can lead to such, novel and innovative educational interventions and whatnot. I think, what comes to mind is, how that happens is also really, really, really important, right? Because recognizing that, faculty and staff, there's a power dynamic there, right, between them and students. So ensuring that we're inviting students and also listening to what they have to say, and taking their ideas and running with it, right? making sure their voices they're not just present at the table, but their voices are heard. And then also ensuring that they are properly compensated for their time, because otherwise we get into a position where we're continuing to extract information and knowledge and expertise and labor from students who often come from, racialized and marginalized backgrounds. And that perpetuates a bit of a problem, right?
You have to be able to change your colors and interact in different ways in different environments. And that's a great point. I'd like to get some practical perspectives from you both, though. One of the things we like to do on this podcast, The Hat Rack, is to provide very practical advice to people so that they can hang their hat on something. And maybe I'll look to each of you to give us one or two things that you would suggest for physicians in practice to focus on with respect to their own personal development that may help them in their professional practice, ideally helping patients, and then down the line, as CPD goes, you help physicians who help patients, that helps a population. So, Justin, let's start with you. What are a couple of really practical things that you might suggest that people can get involved with to help to bring this into their space?
Yeah, I think I think Sukhi mentioned this earlier. Join one of the workshops, come out to one of look for resources and opportunities, right? And build community. I think it can feel really intimidating and scary to have to kind of learn new knowledge and feel like you're not an expert, because I think physicians, healthcare providers, we're all used to feeling like, okay, we know what to do and we know the next step and we know how to approach this. So it can feel really jarring, right? To all of a sudden feel like, oh, I'm out of my depth here. So I think looking for resources, finding community, and we've talked a lot about individual level, doing things at an individual level. But I think it's also really important to look at systems, right? And look at what is our organization doing. So making that ask of the organization to, hey, I want to learn more about this. Please give funnel resources towards this so that I can learn about this and do better for my patients.
Right, so advocating.
Yeah.
Great. Sukhi?
Yeah, I think that there are again so many resources. Even in the 2 years I've been here, it's grown exponentially in different opportunities for learning. One practical thing I think also is just taking a step back and giving yourself some grace to recognize that it is destabilizing to feel like you don't know how to do something that you thought you knew how to do, and you're not seeing.
That's called humble pie.
Yeah. And as much as it's the paralysis or fear of cancel culture or what have you, know and remember that you came into this for a reason, and the guiding principles of caring for the communities that we work, play, and live in hasn't changed. It's the ways in which the populations that you serve or the communities that you're in have changed over time. Be okay with what you're able and capable of doing. It's not going to happen overnight. It's a journey, just like everything, just like the lifelong learning of being a physician, right?
Totally.
It's true. Every 5 years, what you learned is wrong. So,
we all know that.
Yeah. And this is honestly no different, but it's also the complexity here is that we're finally paying attention. Yeah.
Well, listen, I want to thank you both for joining us. This has been a fantastic discussion. As I said before, we could go on for multiple episodes on this topic, I'm sure. So, Sukhi, thank you for bringing your experience and wisdom with respect to this. And she's very humble, but the reason that there are so many more resources here over the last 2 years is 95% Sukhi, because she's done so much work in that area. And it's true. 95 is probably a low number. And Justin, thank you for being here. Thank you for coming to Western and bringing your new perspective for us. And we look forward to seeing lots more from you in the future.
Fantastic. Thanks for the great conversation.
So I guess I would take a few things out of that conversation. A really interesting one and a really different one for the Hat Rack. The first is to think that first of all, it's okay for you to be unaware of something. It's okay for you to realize that you're practicing in a way that maybe could be improved to help the diverse population and the needs of that diverse population you have. So the first thing is bringing an awareness to that and an understanding that it's okay not to know. The second thing is it's really important to understand what your biases are and how to address those. And so we learned that there are resources in place. The one that was mentioned was the EDID website at the Schulich School of Medicine and Dentistry. You can just find it by Googling that, and there are some great resources on there to get you going so that you can do a little bit of self-reflection on your biases, and bringing these things into your own consciousness is important. And then I guess the third thing is just looking more broadly for resources to understand that this is something that's going to change over time. So we have new generations coming through all the time, and our society is changing, and it's up to us as healthcare providers to understand that we need to change with the way in which society is changing as well, so that we can serve their needs. It's been a great discussion, and we look forward to seeing you next time on the Hat Rack.
You've been listening to the Hat Rack, hosted by Dr. Bill McCauley from Continuing Professional Development at Schulich School of Medicine and Dentistry, Western University in London, Ontario, Canada. Technical assistance for the Hat Rack is provided by Patrick Barfoot, Technology Support Specialist at Schulich. Original music was composed by Cameron Bereznik. Please contact us with any questions, comments, or suggestions for future topics or guests. We can be contacted by email at thehatrack@uwo.ca. Additional episode information can be found online at schulich.uwo.ca/CPD. For the Hat Rack, I'm Kimberly Bukala, Educational Developer at Schulich School of Medicine and Dentistry, Western University, leaving you with something to hang your hat on.